part is about the extension of the inflammatory pathology. If the inflammatory pathology in the lungs goes to a level where there would be thick exudates, and the thick exudates fill in the alveoli, and alveoli become what we call as consolidated. Consolidated in the sense it doesn't really become solid, but a bag filled with water, that water-like content, it will be behaving like the solid, and hence we call it as a consolidation. And that kind of condition where the inflammation results in consolidation is considered as a pneumonia or pneumonitis. Now, the pneumonitis is characterized by high fever. Initially, that again it will present in 3 stages: the initial stages of consolidation, then the stage of resolution, liquefaction, then the stage of resolution. The initial stages, there would be high fever, pain in the chest, pain due to involvement of the parietal pleura. At the area where the pleura is involved, the patient would have a pain, and hacking cough, dry cough in the first 1 week. But later on, as the condition progresses, when it enters into the second week, there would be liquefaction, that solidified fluid which is present in the alveoli, it tends to get expelled out, and the patient would have expectoration, which is usually thin, watery, or occasionally purulent. And then the next stage is at the stage of resolution, where there will be gradually recovery, and a classical case of pneumonia would resolve in 3 weeks, or there could be an extension further and major complications can occur. Then there is another issue of non-resolving pneumonia. A pneumonia which doesn't resolve in 3 weeks, there will be always some other underlying pathology which needs to be evaluated, and that becomes a very complex issue. And a typical resolving pneumonia would be presented in the form of either in the initial stages with the dry cough, that's what is considered as vatajakasa, kupito vatali vatha, shushka urak kanthavaktratam, hritpasha uras shirashulam mohak shovasvarakshayana, karoti shushkam kasam, that shushka kasa, and mahabega, that sound also is quite characteristic, and maharuja and mahaswara, there would be pain and persistent cough, as well as the sound produced of cough also is typical, which you call as a hacking cough. So angaharshi kapham shushkam krichat muktwal padam praje, that's the typical presentation in the consolidatory phase of vataja kasa. Whereas once it becomes the next stage, the liquefaction stage, that's the typical presentation of sarpurvam kasave shushkam tatha stivet shashonitam kanthe rujata atyartam virugnenev chaurasa suchi bhirva tikshna bhitudyamane shulina dukkasparshena shulena bheda peda bhidapina parva beda jara shwasa trashna vaisware peditaha paravadiva pujan kasave rakshatodbhavan. It may result in the features which look like kshatraja kasa, where there would be liquefaction, and then the clinical symptoms would become more severe. That's exactly the clinical features of vataja kasa. Converting into the kshatraja kasa is the typical phase of pneumonia, consolidatory phase, and the liquefaction phase. Typical clinical presentation, when you auscultate, there would be in the initial stages there will be bronchial breathing. Then in the next stage, liquefaction, there will be crepitations present, and in the resolving phase, the later phases, well, crepitations become reduced, occasionally inspirated bronchi could be there, and then the blood sounds become normal. Ideally, a pneumonia would be resolved in 3 weeks. Now, the other evidence would be like there will be raised leukocyte count. X-rays, radiologically, they will show you typically the consolidation, the solidified area with that typical anatomical broad limitations. In case of the consolidatory phase, liquefaction phase would show that presence of air in the alveoli. So multiple, it's something like advanced mottling or a dense mottling can be seen in the stage of liquefaction, and ideal resolution, there will be no findings later on. Treatment in that condition is if the patient of pneumonia has a total count of more than 16,000, I would prefer antibiotic therapy is needed, and particularly in children, it may be antibiotic may be needed, or if there is a coexisting disease, then again antibiotic treatment may be needed. If not, in these conditions, other than these conditions, pneumonia can be resolved sufficiently in Mrityunjaya Rasa in the first week. If in the second week, Lakshminarayana Rasa, because it resembles that of the Vishamata, Vishamajwara features. And Makara Lavasud Mission Amritarishta or Somasa or Basakarishta, that depends upon the issue. So Amritarishta in the febrile stage of first week, Somasava in the second stage or liquefaction stage where the expectoration would be more, and Vasakarishta in the conditions which persist for a longer duration, or the cough, there would be more of wheezing like symptoms. In such conditions, the treatment can be done, and that would be the usual treatment in case of pneumonitis. That's about the issue. But a pneumonia which doesn't resolve in 3 weeks, it requires a thorough investigation, and the underlying causes have to be identified. Many times there could be serious underlying causes like tumors or occasionally tuberculosis, or there could be a foreign body aspiration pneumonia could occur. So aspiration pneumonia is something different from this infective pneumonia, and all of them would have a different sort of prognosis, and the treatment may not be as simple as the conditions as such. So that's about one of the issues. Next common condition related to the Pranavahasrotas would be the patients who have continuous persisting breathlessness, which we call as a chronic bronchitis like condition. Chronic bronchitis conditions, of course, also is often named as a chronic obstructive pulmonary disorder. But actually patients who develop that breathlessness for a long duration, they would have either an obstruction in the sense where the air is not able to enter in, or it could be restrictive. Restrictive is there is a resistance in the lung tissue. Lung cannot expand, and that kind of a condition is the restrictive, where the expansion of the lung tissue is affected. Of course, in a typical chronic bronchitis, there could be more both obstructive as well as restrictive. But the differentiation between obstructive and restrictive is necessary if you are planning for the treatment like a bronchodilators. See, in a typical obstructive pathology, because the respiratory passages are obstructed, and a drug like a bronchodilator, which increases the diameter of the air passages, can help in resolution, but in at least clinical symptoms may be resolved. Whereas if there is a restriction, that's the movement are reduced or the lung is not able to expand at all, in such conditions bronchodilators may not help, rather they may worsen the condition. There the treatment protocol is somehow the air exchange in the lungs have to be enhanced, and that is the basic issue. Now these kinds of obstructive and the restrictive components of a chronic lung pathology is described very clearly in Charaka Samhita in the context of the Shwasavyati. Dirgham Shwasati Yastu Urdham Na Pratyahara Vyadaha Shleshmavadamukha Krudda Gandhavaharnitaha Urdhva Drishti Vipashimsya Vibhranta Shaitasthadaha. That's the typical presentation of obstruction, where the Shleshmavadamukha the srotas or the passages, they are obstructed, and hence the Gandhavaha, that's the air, is not able to enter in. Whereas the other way, Pramuhyan Vedanarthascha Shushkasya Aratipiditaha Urdhashwase Prakupini Adashwase Niruddhyate. In such conditions where there will be a restriction, the patient may be able to breathe in, but breathing out, expiration would be difficult, and there will be more of efforts of expiration. That accessory respiratory muscles will come into picture there, and that's sign of the restrictive pathology. Muhyata Tanyatascha Urdhvam Shwasaha Tasyaiva Hantyasun Iti Urdhashwasaha. That's about the clinical features of the Urdhashwasa. Now obstructive and restrictive differentiation is again quite important. In a typical obstructive pathology, the patient in a normal typical condition, inspiration volume is quite good, and the equal expiration volume also would be almost equal, but expiration is a relatively slow process. In a typical obstructive pathology, the total volume of inspiration is lesser and the expiration is more prolonged, but it equals the volume. In a restrictive pathology, there will be a difficulty in inspiration. Time taken for the inspiration is actually time taken for the initiation of the inspiration would be more, and the expiration also will be shorter. So there would be patient would have a rapid breathing, and this can be differentiated very accurately with the spirometry, but it's not necessary to have the spirometry in all such conditions. A simple observation can help you. The rate of respiration in case of obstructive pathology will be more, whereas in restrictive pathology the rate of respiration may not be increased to the same extent. The volume and the time taken for the expiration in case of the restrictive pathology, there will be always a shortness of breath. The inspiration and the expiration will become rapid, whereas in case of obstructive pathology, inspiration is shorter, expiration takes more long. Accessory respiratory muscles, they are always in activity or more severe activity in restrictive pathology than the obstructive pathology. That's how you can make out. Or on auscultation, the obstructive pathology, you can make out that phase of expiration which is prolonged. Inspiration is shorter, intensity of the inspiration is lesser, and there is a gap in between the inspiration and the expiration. There is a gap. In case of restrictive pathology, inspiration and expiratory sounds will be almost equal or low intensity. Time duration of the expiration also would be shorter in case of restrictive pathology. So a careful auscultation is good enough to make out obstructive and restrictive differentiation. And of course, spirometry, if you have the facility of the spirometry, you can objectively define in which of the patient which component is there, and that's a very important issue. In case of the restrictive pathologies, among the restrictive pathology, the most common condition which we see would be what we call as interstitial lung disorder. Interstitial lung disorder is where the collagen tissue in the lung tissue has become affected, and hence the lung is not able to expand. And it's not again produced with a single disease. It could be multiple causes which could be produced, like often it's produced due to exposure to the irritant substances. Persons who work in exposure substances which affect like asbestosis or so on, or pollution as such, or in the conditions like rheumatoid pathologies, SLE, etc., there could be collagen tissue disorder. And certain of the drugs also can induce the interstitial lung disorder, like steroids. Steroids given for a long duration can produce interstitial lung disorder. And typically, the clinical history in such condition, the patient would have severe exercise intolerance, cough would be dry, and there would be repeated episodes of crepitations with the reduced inspiratory sounds which could be seen. Club fingers, scleroderma also could be seen, that changes in the skin and the fingers, the nails will become club shaped as such, that also could be presented. And in such conditions, the treatment would be Shasakutara, Arogyardini, Pipallasa or Draksharista. Something like Balya Rasayana Aushadhis also may have to be given. And it's because Amashayotha Vyadi, Shudra Swasa, in such conditions, Avipattikara Churna or Godati, and usually Avipattikara Bidlu Godati can help. And Pranayama also helps significantly. Virechana is quite useful in such conditions. Important is bronchodilators would worsen the condition. Patients who are, and majority of the patients who come to Ayurvedic clinics would be of this category, because in the contemporary system, the very common prescription is some bronchodilators which are prescribed, and the bronchodilators do not help in such conditions. The only, if at all the contemporary treatment is required, it could be the glucocorticoids, which could be, and very interesting is glucocorticoids could aggravate the interstitial lung pathology, but in a established interstitial lung pathology, that's the only solution which you have as such, that's the remedy. But our treatment would be much better than the other way. And this is exactly what's the Kshudra Shwasa, Rukshayasa Udbhavaha, Kosthe Kshudro Vadamudiren, because it is a Kostre Vyadi, we will give Avipattikara Churna, like which such drugs will help a lot. And Virechana also could be helped as such. And the typical presentation of this restrictive pathology could be where the volume of the lung could be reduced due to some previous injury, surgery and so on. In such conditions again the treatment will be same. And of course Chavanaprasha like Rasayana Aushadhis also can help in very chronic lung disorders where the lung volume is lesser. Then the typical obstructive pathologies where there could be allergic pathology, in such conditions Kaphoparuddhagamanaha Pavanaho Vishwagasthitaha prana udaka annavaheni dristasrotamsi dushan urasa kurute shwasam amashe samudbhavam. Another of the condition, that is the where there is a typical obstructive like allergic pathology or patients who have emphysema like conditions where the breath are shorter. Auscultatory findings, typical emphysematous breathing, the inspiratory and expiratory gap would be shorter there, and the patient tend to have a very chronic pathology. In such conditions, again, the treatment would be almost similar, Shasakutara Punarna Mandura, but instead of like LSM, I would prefer schizopathy because there would be more of involvement of Vata and Pitta, and Mrudu Dravya may have to be needed, or Ayurvedic also is suggested as a treatment. Virechana could be quite useful. And in all these conditions, there is no question of a complete cure, and it's only the question of palliative management. In a typical emphysema, radiological findings would be the density of the air in the lungs would be more, and there could be even tinting effect. The diaphragm may be lifted up at that area where the emphysema, local emphysematous bulla has occurred. Now that's in general about that. Then there is another condition which is called as the respiratory failure, where respiratory failure is defined as a situation where the air exchange or the gas exchange will not be enough to manage the physiological functions of the body, and then again it could be of two varieties. A type 1 respiratory failure where the total oxygen concentration is less than normal, either in the air available or the air is not reaching to the lungs as such, and it could be produced due to the damaged lung tissue like tuberculosis, pneumonia, or any other acute respiratory distress syndrome, or any fibrous lung tissue as such. When the lung is not able to exchange the air in the alveoli, that condition is called as type 1 respiratory failure. Type 2 respiratory failure is a ventilatory failure where the air cannot enter into the lungs. The mechanical efforts of taking the air in is not available, is not possible, and hence there will be low oxygen as well as carbon dioxide content will be more. Whereas in case of type 1 respiratory failure, the oxygen level will be lower, carbon dioxide level also would be almost of the same category, it may not be raised, and it usually occurs due to obstructive pulmonary disorders or chest wall deformities, muscular or neuromuscular pathologies. The important is, in case of type 1 respiratory failure, low oxygen condition, you have to ensure that there is some better air exchange in the lung tissue. Simply providing oxygen would not be enough, but increase the oxygen concentration in the air breathed in can help the patient, like whatever the methods of our oxygen administration, I will come to that part. If you administer the oxygen, that can improve the condition. Whereas in the patients who have ventilatory failure, type 2 condition, simply providing the oxygen is not enough. You have to ensure that the oxygen is pushed into the lung tissue with what we call as CPAP machines, or maybe ventilators, the obvious ventilators. If we remember the patients who was there earlier in 148 for quite a long time, simply providing the oxygen would not be enough. You have to have a pumping, oxygen pumping has to be there, because the patient had a neuromuscular pathology where the patient was not able to put in enough of breathing effort. Now, differentiation of these would be often, many times, clinically is possible, but many times you may need the investigations like blood gas analysis, spirometry, or pulse oximetry, which together may have to help in making that. The typical signs will be like dyspnea, patient would have cyanosis, neurological manifestations also occur due to the hypoxia. When there is a hypoxia, there will be cyanosis, dyspnea, acidic seizures, the patient would not be able to have a proper gait. Seizures or even coma can occur in such condition. That's exactly what we see in Tamaka Shwasa. Ativa Tibrvegam, Shwasam Pranapedakam. Pratamyati Savegana, Drishyate Sanirutite, Pramoham, Kasamanascha, Sagachati Muhumuhu, Shleshmanyam Uchamane, Brisham Bhoti Dukkitaha. That systemic features tend to occur, and that's exactly the Tamaka Shwasa as such. Acute respiratory distress syndrome is one of the serious condition where there could be fatal complications occurring, where again the patient would have a hypoxia, and the Diagnostic criteria is there should be tachypnea and dyspnea, and there should be crepitations present which are developing suddenly, a sudden development of tachypnea and the basal crepitations, and there could be evidence of some process where the lung is either injured due to sepsis, or there could be somehow the air is not able to enter into the lungs due to aspiration, which often occurs in patients who are being treated for cerebrovascular accidents, etc., coma patients as such. And when there is a evidence of fluid in the lung tissue, acute respiratory distress syndrome can occur, and that evidence could be seen in the X-rays. And if even when you use the lung mechanics like ventilators, if the patient is not able to respond to that ventilator, and the required pressure could be more than 40 milliliter per cm water, and severe hypoxia refractory to oxygen therapy, where simple oxygen is not enough, that will be considered as acute respiratory distress syndrome, which can be quite fatal, and you need a high level of this ventilation. So that's one of the condition. Or another way of treating such condition would be to reduce the fluid in the lungs. You may give a diuretic. Now, in our setup where we do not have a ventilator, the usual protocol which we follow is giving a diuretic can somehow help, though not as effectively as that of the ventilation. By giving diuretics, the flooding in the lungs can be reduced to a certain extent, and the patient can breathe somewhat better. Now, in all such conditions, administration of the oxygen is one of the important issues. Administration of the oxygen requires certain basic ideas, basic perceptions. The oxygen is a drug, and it cannot be just taken in as you like. It needs prescription, and it's a treatment for hypoxemia. When the concentration of the oxygen in the blood is lesser, in such conditions, oxygen is to be given. And the target of oxygen concentration would be, if the patient has a type 2 respiratory failure, in such conditions the target could be in between 94 to 98%. To get that target saturation is the most important issue. And if the patient is not in established risk of respiratory failure, then the target could be slightly lower, of 88 to 92%. And supplement oxygen may not be required. And the oxygen delivery systems could be nasal cannula, which we often use, simple mask. I think you have seen that. Whereas others may not be seen in our setup, like partial rebreather mask, non-rebreather masks, venturi mask. In all these, there would be a gradual slight increase in the ability of the instrument to increase the concentration of the oxygen. And I think these we have discussed in detail when we discussed about the emergency medicine earlier. So I will not go much of that. But important is, ambu bag would be the first of the thing where the volume, the pressure of the oxygen administration can be enhanced. Then of course you have the tracheostomy, the methods where instead of that simply providing oxygen from the exterior, open the trachea, put in a tube, and then directly administer the oxygen into the lungs through a machine, ventilatory machine. So it's about just gradual level of increasing the ability to increase the concentration. And in general, hypoxia is again classified as a hypoxic hypoxia, where the patient is not able to get oxygen in sufficient conditions. Then anemic hypoxia is where the oxygen carrying capacity of the blood is lesser. Stagnant hypoxia is where the blood cannot circulate to the periphery, and in such conditions, though if you increase the oxygen concentration in the blood, the patient would not be able to, tissue would not be able to receive that, like patients who are in shock where the blood pressure is lesser. Or cytotoxic hypoxia, where there is some toxic substance like carbon monoxide poisoning, and hence the cells are not able to take the oxygen in. Now, all that oxygen administration which we have discussed would be useful only in hypoxic hypoxia, where the concentration of the oxygen is lesser. In other conditions, simple administration of the oxygen in any of these means would not help. That's the important thing. So, when a patient has a hypoxia, the utility of the oxygen administration is limited to only the hypoxia, and where the patient has a A one type of the respiratory failure, simple methods of oxygen administration would be enough. Whereas if the patient has a type 2 failure, ventilatory failure, efforts of ventilation can help. If the patient has a lesser oxygen carrying capacity in the blood, simple administration of oxygen would not be enough. You need to ensure that the oxygen carrying capacity is enhanced by either giving blood or so on. In a stagnant hypoxia where the circulatory pressure is lower, you have to ensure that the circulatory pressure is corrected with the drugs, relevant drugs at that moment. And cytotoxic hypoxia, virtually there is no cure. If at all possible, that toxic substance has to be removed, and then the oxygen tissues condition can be improved. So it's not that the oxygen administration is a solution for all the problems. Now I think when we say that pressure, with the pressure, positive pressure, CPAP or bilevel PAP is the other technique, that's not necessary. We'll leave it at that level. Another of the conditions related to the lungs and which are quite common is pulmonary tuberculosis. Pulmonary tuberculosis is exactly the Kshaja Kasa. Tuberculosis, of course, is a mycobacterial infection which is transmitted through the respiratory passages as such, and it produces the granulomas and later it results in fibrosis. And the clinical signs are chronic history, low grade fever, thick expectoration, and usually a cough which is persisting for more than 3 weeks, emaciation, bronchial breathing or cavernous breathing, hematemesis could be there, and majority of the patients it could be triggered due to reduced immunity like diabetes and HIV, etc. And that's exactly what the clinical features say about the Kshaja Kasa. Sagatra Shula Jwaradaha Mohan Pranakshayam Chakulabhetakasi Shushyant Ministivati Durbalastu Prakshinamam Saha Rujiram Sapuyam Sarvalingam Vrishadushtikitsam Chikitsitajnaha Kshayajam Vadanti. Kshaja Kasa is one of the issue. And in all such conditions, the confirmatory evidences would be either radiological evidences where you will see the different radiological evidences of the tuberculosis starting from simple areas of consolidation to the cavities or even collapse of the lung tissue. Atelectasis also could occur. So a typical caseating lesion where you will have a ring-like lesion, or atelectasis where the lung tissue has become reduced in size and air is not able to enter in. So tuberculosis can produce multiple radiological evidences. And the confirmation of the diagnosis would be by confirming the evidence of tubercular organism in the sputum. 24 hours sputum test also may be required, or now immunological test to confirm the tuberculosis also are done. Treatment of tuberculosis as per the current protocol and from the National Strategic Plan for Tuberculosis, treatment of tuberculosis should be done only after declaring the patients of tuberculosis in the Nikshaya protocol, Nikshaya portal. It's necessary, mandatory. Of course, there is till now no punishment is decided about if you treat the tuberculosis without declaring this, but it is considered as unethical. So if at all you find a patient of tuberculosis, it's absolutely necessary that you have to declare that patient or announce the patient in the register the patient's name in the Nikshaya portal, and the treatment should be under the guidance or under the control. This is the ethical necessity, I would not say a legal necessity, and maybe in due course of time it may become even legal, mandatory. So treatment should be done as per the protocols decided by the central government as well as the state government, the health authorities rather. And the current treatment would be multi-drug therapy and under the direct control, which you call as dot therapy. So that has to be done, and there is no question of treating only with the Ayurvedic treatment. But if the patient has other conditions, after having those, to support the condition, what I would prefer is Arogyavardhini, Kumariyasava, Makardhaya, Lavsud Mishrana or Rasayan therapy like Chavanaprasha. If the patients have become resistant to multi-drug resistant therapy conditions, the treatment can be somewhat with our treatment like Lakshminarayan, Arogyavardhini, Makardhaya, Abrakavasana, Sitopaladi, Vasakarishta or Draksharishta could help in ameliorating the symptoms, though I don't say curative. The treatment of tuberculosis with Ayurvedic drugs alone, again, as per the current legal issues, it would be unethical. I would not use the word illegal, maybe in due course of time it may become illegal. So that's the one part. Then it comes in pleural effusion or urakshata, the fluid in the lungs. Now, fluid in the lungs can be produced due to multiple causes. Either it could be due to the trauma, it could be due to infective pathology like tuberculosis or so on. And such conditions, the treatment protocol would be based upon the issues, but there is some general approach of treating this pleural effusion. Description of the pleural effusion in the Samhita is quite important. व्यायाम भार अध्ययनैः अभिघात अतिमेथुनैः कर्मणा चापि उरस्येन वक्षो यस्य दारिद्र्यं तस्य उरसि क्षते रक्तं पूय श्लेष्मा च गच्छति. ट्रॉमेटिक इंड्यूस्ड कंडीशन. कासमानः छर्दे च पीतरक्त असितारणं संतप्तवक्षः हसोत्यक्तं दूयनात् परिताम्यति दुर्गन्धवदनोच्छ्वासः भिन्नवर्णस्वरो नरः. Whereas the हृदय मर्म अभिघातजन्य मर्म अभिघातजन्य and the other marmas, the marma vidya lakshanas. In Sushruta has mentioned Saptarajasma adhishtanam hridayam tatrapi sadhya maranam स्तनयोः अधस्तात् द्वङ्गुलम् उभयत स्तनमूले तत्र कफपूर्णकोष्ठतया म्रियते. That kapapurna is the typical evidence of the conditions where there will be fluid there, whereas whatever is mentioned as urakshata is a evidence of pyothorax. And where there would be kaphapurnataya, hydrothorax like conditions, where like congestive cardiac failure, renal failure like conditions, where there will be fluid accumulated over the area. And that's the typical sign of stanamula marma abhigata lakshanas. Stana chuchake urdum dvangulam ubhayat stanarohito tatra lohita purna kosturaya kashaswasabhyarjam riyate. In the stanarohita marma abhigata, there would be blood filled cavity in the chest and the hemothorax is described. And अंशपुट यतस्तात् पार्श्वपरिभागः अपलापो नाम तत्र रक्तेन पूयभावं गतेन मरणं, where there would be again a pyothorax and that has to be treated. So important is such conditions are specified, whereas a pneumothorax vatapurna koshtadaya, that's in case of apastambhanama tatra vatapurna koshtadaya kashaswasabhyanja maranam. Evam etani udara, that's about the description of the marma. But these marma abhigata lakshanas, they have clearly described about the conditions. Now, irrespective of the causes there, in any of these conditions, effusions, they require the tapping, and the tapping has to be done either for diagnosis or curative depending upon the condition. And the treatment would be as per the necessity, like as per the underlying pathology. Tuberculosis, it would anti-tubercular treatment. Neoplasm, that anti-neoplastic treatment. Pyothorax, antibiotic therapy may be required. So I would not say a generalized single entity. Along with that, our drugs can be used. Along with those primary treatment protocol, our drugs can be used, which I would prefer as Goksharavigul Punarnamda Pushkara Mulasara. Again, I repeat that it's not that we treat the patients, all patients of pleural effusion on the same line. The treatment of pleural effusion would be diagnostic tapping is required, and after the diagnosis, according to the condition, the treatment protocol has to be planned, which is again a quite elaborate issue. And the supportive treatment would be Shotagna as such. Pericardial effusion is another of the condition which we rarely get, but still Sushruta or maybe clinically we may see such conditions, which could be again of multiple causes. And the evidence of pericardial effusion would be where the patient would have a reduced cardiac compliance, and the radiological evidences would confirm that. That's typical of the Hridaya Marma, Shleshmana Hridayam Subdam Barikam Sashmadarbhavat Kasa Agnisathanishtiva Nidra Alasya Ruchidvaraha. When the Hridaya Marma is involved with the kapha, that is a typical presentation of the pericardial effusion. That again, the treatment would be based upon the exact causes, and I would say that our management would be a curative management. But along with whatever the basic treatment protocol as per the causes, Prabhakaroti Punarnamandura Punarnavasa can help the conditions. Then to the other part is the extrapulmonary pathology is presenting with the respiratory symptoms above the Pranavahasrotas. Again, though the patient may have the diseases elsewhere, but the patient may have a Pranavahasrotas involvement. Among them, pulmonary hypertension is one. Pulmonary hypertension may be produced due to congestive cardiac failure, or it could be due to the vascular pathology, renal pathologies also, so on. So, in a patient where the circulatory pressure in the lung is more, or it could be due to primary cardiac pathology, like valvular defects and so on. In such conditions, the treatment has to be according to the cause. So, a patient of pulmonary hypertension has to be diagnosed properly, and whatever the possible mechanical treatment required has to be done. So, I would not go into that. Our supportive management, a patient of pulmonary hypertension can be somehow managed symptomatically with the Punarnamandura, Prabhakaroti and Punarnavasa, but the primary would be as per the real causes, whether the patient has rheumatism or valvular pathology or so on, the treatment protocol has to be applied. Congestive cardiac failure is another of the condition where the patient may have respiratory symptoms due to the congestive cardiac pathology, and that's again a sort of pulmonary hypertension where there could be accumulated fluid in the lungs. In such conditions, actually the drug like digoxin is absolutely necessary. Along with that, the same Punarnamandura Punarnavasa can be useful with our treatment protocol, and that's exactly described as the kapavatatmaka, that's in the Shwasakasa, kapavatatmaka veto, Pittastana Samudu, Hridaya Sirhadinam, Dhatunam, Jopashoshano, Tasmat Sadharana Veto, Mato Paramadurjayo, Mithyopajarita Kurdu, Ita Ashi, that extension of the Shwasakasa could result in congestive cardiac failure. Causes of the congestive cardiac failure and their management is another issue. Of course, digoxin is one of the common management which may be necessary, along with other causes have to be done. And that's about the issue. The last part in the respiratory tract pathology would be tumors of the respiratory pathway. Again, it's again a huge issue. The tumors are classified as based upon their nature. Primarily, the initial simple classification is based upon the histological evidence like adenoid cystic carcinoma, squamous cell carcinoma, carcinoid, and mucoepidermoid carcinomas. Nodules, non-small cell lung cancers, small cell lung cancers, mesothelioma, and primary tumors that are adjacent to and invade and compress the airway, cancers that metastasize into the airway. These are the typical varieties. WHO has made it a more complicated issue, and as per the statistics, lungs pathology, tumors of the lungs are very common. 2.21 million cases of lung cancer and 1.8 million deaths from lung cancer occurred in worldwide 2020. And one of the important issues is tobacco smoking is the most predominant cause of lung cancer and only means of decreasing the incidence of this as overall. And with all the protocols of treatment, advanced treatment, only 2% are alive at 5 years. The maximum life period in lung cancer is 5 years, and only 2% can survive up to that level. So that's in brief about the whole picture of the lung cancer, and that's why it has become quite important. And lung cancer classification made by published by WHO in 2021 is quite very elaborate, and though there is no question of a proper treatment, the ICD code and that the classification is very elaborate. I think that kind of detail is not necessary, but with the only purpose of sensitizing the complexity of the condition, I am just presenting this. The epithelial tumors, again, they are subclassified into squamous cell carcinomas and so on, and adenomas again subclassified into categories. Again, precursor glandular lesions, adenocarcinomas with the minimally invasive adenocarcinomas, invasive and non-invasive, non-mucinous adenocarcinomas, squamous precursor lesions, squamous cell carcinomas, basaloid squamous carcinomas, large cell carcinomas, sarcomatoid carcinomas, neuroendocrine disorders, neuroendocrine carcinomas. These are the different classification of the WHO. Again, going into that detail is not worth from our point of view. In oncological practice, these are essential because many of those new generation drugs, they have a specific target oriented, and hence this classification has some value in selection of the new target oriented anti-tumor drugs. Now, so we will not go into the complexity, so we will just leave at that issue. Come to the clinical presentation. The majority of the patients of lung carcinoma, the clinical presentation is quite atypical. It's again very difficult. The common clinical symptoms which could be seen are cough, seen in 8.75%, weight loss in 0 to 68%, and dyspnea 3 to 60%, chest pain 20 to 49%, hemoptysis 6 to 35%, bone pain 6 to 25%, clubbing in 20%, 0 to 20%, fever 0 to 20%, weakness 0 to 10%, and severe ventricular obstructions 0 to 4%, dysphagia is 0 to 2%, wheezing and stridor in 0 to 2%. This is based upon Harrison's principles of internal medicine. I have just copied it. The point is, the clinical presentation is quite atypical and it is very difficult to manage. There are no specified standard methods of diagnosis. Hence, radiological evidences would be quite useful. Radiological findings in case of tumors of the lungs also could be quite varying. The most common variety which we see here would be non-small cell carcinomas, or which we call as word cell carcinomas, which would be presented as a solidified area consolidation with the is crossing borders, which is not limited by the physiological barriers, and which could be limited to only one area, one component of the lungs, either the anterior or the posterior. In this case, it is in the posterior area, you have that consolidation. Or it could be nodules, small or multiple nodules, which could be presented, which also could be seen in the X-rays, and the chances of missing these nodules also are quite high if you are not alert enough. Or pancreas tumor, where it will be invading into the peripheral pleura and produces the pain in the brachial area, brachial plexus compression, and the brachial nerve pathology can occur, which we call as a pancreas syndrome, could be the presentation. Radiological evidences, they are again can quite wide varying, and hence a summary of that radiological evidences is presented here, where you may have either a single node or a peripheral mass lesion, or there could be a cavity, or there could be infiltrating area, or there could be pleural thickening, or there could be a mass in the hilar area, or there could be a mass in the apex area, or the whole lung tissue can be involved, or there could be atelectasis, lung tissue may get collapsed as such, or there could be pleural effusion. These are the various clinical radiological evidences of the lung carcinoma, and that makes the diagnosis difficult. With this, we will just say there is no curative treatment. The only supportive treatment from our point of view will be Aragyavardhini Kumari Asava. As I told, the prognosis of lung carcinoma is quite poor. With this, we will wind up the Pranavahasrotas as such. The next we will take up Annavahasrotas in the coming session. If there are any questions, right, there are no questions, so we will wind up. Next we will take up Annavahasrotas.